वंदे मातरम 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 मातरम वंदे सुजलां सुफलां मलयज शीतलां शस्य श्यामलां मातरम वंदे मातरम वंदे मातरम वंदे मातरम वंदे मातरम सुहासिनीं सुमधुर भाषिणीं सुखदां वरदां मातरं वन्दे 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 मातरं सप्तकोटि भुजे धित थर करवाले सप्तकोटि कंठ कल कल निनाद कराले सप्तकोटि भुजे धित थर करवाले अब लगन मात वाले बहुबल धरणीं नमामि तरणीं विपुदल वरणीं मातरं वन्दे मुलाकात हो रही है देख रहे हैं आपसे मुलाकात होती है। अरे यार चलो बाबा मनोहर सर को लाइन में खड़ा कर रखा है, संभाल रहे हैं यहाँ। इतना बुरा मत नहीं है यार। all the way around, and then
फोन करा के बंद कराओ, चेंज कराओ।
सुहासिनीं सुमधुर भाषिणीं सुखदां वरदां मातरं वन्दे 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 मातरं। सप्तकोटि भुजे फित थर थर वाले, सप्तकोटि कंठ कल कल निनाद कराले, सप्तकोटि भुजे फित थर थर वाले, हनुमत बोले बहुबल धरणीं नमामि तरणीं विपुल हरिणीं।
Dr. B. Bhandari, the founder of this department, please come on the dais. Co-chairperson of this scientific committee, Dr. Pankaj Doshi, popularly known as Bhamasa among the pediatricians of the Dr. R.S. Suman, chairperson of the scientific committee, to welcome Dr. R.K. Agarwal sir. Meanwhile, two of my Dr. Mohammad Asif, Joint Organizing Secretary, to welcome Dr. D.D. Gupta sir. Dr. Hemant Kumar, Treasurer of the Organizing Committee, to welcome Dr. A.P. Gupta sir. And Dr. Rajesh Malik, Chairperson of the Reception Committee, to welcome Dr. Dabi sir. So at the outset, Apurva to come dais and sing the Saraswati Vandana. distinguished guests on the dais to please lit the lamp and declare.
Head of the institute. सर आप जुड़िए सर आगे सुमना आसिफ बाबू हम साथ ही
अरे एक बार
one book on tests and procedures, and I request Dr. Bhupal and the editor to come and get it released by the chief guest, Dr. D.P. Singh sir. Sponsored, the whole book is sponsored by Vedanta Group, that is Hindustan Zinc Private Limited, and Dr. Prakash Bhandari Saab and Dr. Karuna Bhandari. They are the chief medical officers in Hindustan Zinc. They have really done a wonderful job by finding the publisher and the sponsor of this book. So, I request all of you to please give a big hand to Dr. I hope this book will be useful especially for the young pediatricians and for the resident doctors, because pediatrician from Jodhpur, Dr. P.D. He is a dedicated pediatrician, and his dedication for the teaching, for the education seminars. So please give him a big round of applause. And compliments to Dr. Shri for such a nice occasion. Now I request
My esteemed teachers, senior faculty members, distinguished faculty, delegates, friends, and their family members. On behalf of Organizing Committee of RAJ NEO PEDI CON 2014, on behalf of Indian Academy of Physics, Rajasthan and Udaipur chapter, and on behalf of Department of Physics, RAJ Udaipur, I feel proud to be here on the dais and really feeling very happy I got the occasion to organize this conference. I have been attending these conferences for quite some time. Day by day participation in the conferences, Pedicon and Neocon, was not very much. I thought there is a lot of wastage of time of faculty, the delegates, the sponsors, their money and time was wasted. So this time, for the first time, we have combined both the PGT conference of the state and neonatal conference of the state. And you will be happy to know that we have almost more than 400 delegates, which is almost a record for a state district hospitals, private hospitals, have come here to attend the conference. This conference will be a mix of good academics and social, and the attendance in both the three conference workshops, one on advanced meditation and another on NLP, was excellent. We expected almost 40 participants in both the workshops, but we had more than 50 registrations in advanced meditation workshop and around 50 registrations, and taken place for the welfare of children of our country. Today's program was supposed to start around 9 AM. We are quite late. We are will not extend in our function. This year is the 50th year of Department of Pediatrics and Rajpedicon. So we are trying to contact the alumni of.
It is true, you all know that time to come forward and join hand with Sardar Vallabh Bhai Patel for a united free India. In the same fashion, to step in this noble tradition, our chairperson Dr. Suresh Goyal Sahab has done a wonderful job of combining these two conferences. Now, I request our chief guest Dr. D.P. Singh Sahab to say a few words.
Respected guys, distinguished guest speakers, dear delegates, ladies and gentlemen and kids, I am very happy that RAJ NEO PEDI CON, Dr. Lakhan Poswal and organizing team has worked hard for last 1 year to make this conference very successful. I wish this RAJ NEO PEDI CON 14 a great success. Thank you very much.
Professor of Pediatrics at SMS Medical College, and Dr. A.K. Kamdar Sahab, a very senior pediatrician from Jaipur.
I have to be a little bit faster because we are already running late. So, approach to stand febrile encephalopathy. First of all, I would like to give some definition about related with the topic. Encephalopathy means clinical syndromes of altered mental status presenting as a reduced conscious state or altered behavior without the inflammation. While in febrile encephalopathy, we get acute onset of fever less than a week plus alteration of consciousness more than 12 hours. Encephalitis, as we commonly use, it mainly a dysfunction of the brain associated with the inflammation, and it is a strictly pathological infections of the nervous system. ADEM and the space occupied lesion can present with acute febrile encephalopathy. Commonly known viral encephalitis organisms are herpes simplex, varicella, Epstein-Barr virus, arbovirus in which we get Japanese encephalitis, dengue and chikungunya, retrovirus, rabies, automyxo, H1N1, swine flu we are getting, and paramyxo, measles, and of course the HIV and the influenza. In bacteria, we have pneumococcus, streptococcus, H. influenza, and Listeria belli. But we can get leptospirosis, typhoid, tuberculosis,
and this is our hospital, Texas Children's Hospital. It's the largest pediatric liver center in the country, and we do around 40 liver transplants for children each year. So this issue becomes a big issue for us. So what I'll talk about is something I said that's a little different between the US and India. It turns out that your chapter, but we'll start with the case. And this is a 4-year-old boy from a small village, presents to you, pediatrician, after receiving advice from the village.
Intensivist at Bhupal Hospital, Jaipur.
sorry.
Advanced life support begins with good basic life support. And if you're familiar with the 2005 guidelines, everything was complicated. In the newborn you do this, under 5 kilos you do this, above 8 years you do this. It became very complicated. And when the child is almost an adult you do this, and an adult you do this. And it was just too much. How do we remember all this, and how do we start assessing age, weight, etc., when you're dealing with different people? And on top of that, there were all these things while out of hospital you do this, just at the door of the hospital you do this, in the ICU you do this. It was all complicated. When people sit down to make these guidelines, they also want to
useful guidelines to call it a respiratory failure. Now, why are children at increased risk of acute respiratory failure? We know that many times the X-ray is not showing anything much. Okay, you're seeing some streaking, mild hyperinflation, but the child is in respiratory failure. And that's because there's a number of vulnerability in the pediatric age group, anatomical, alveolar and bronchial or alveolar communications, which in an older patient prevents atelectasis from developing. These are the Conn spores. They develop by 2 years, Lambert's channel by 7 years. So you can see the Conn spores are the alveolar communications. These are the Lambert's channels, bronchiole to alveoli, and Martin's channels, interbronchial. The purpose of this is, supposing this alveolus is not well aerated, it can still get collateral aeration from the neighboring alveolus and bronchioles. These are not present in infants, they develop later. But most important than that are the physiological type. So that's why your X-rays may not look bad, but the physiology is getting affected very badly. The fourth important physiological limitation is the dynamic airway collapse, which spontaneously as well as in mechanical ventilation. But in the child which is not at all uncommon in small children, they breathe as active expiration. Then the same thing happens. They are closing the terminal airways which do not have cartilage and are actually suffocating themselves. They are not
सबकी फोटो ले लो
and not trying to give him proper position, etc. They anticipate the difficult airway in distribution, intubation. So have experts available to support you in case he needs intubation. Very important to the child may be there. Always go clinic. If your child is worsening, the diffractions are worse, sensorium or deteriorating, this child needs mechanical support.
मुझे बता देते Good, good.
मुझे बता देते हैं
लगा पूछो नहीं थोड़ा
नहीं ये पापा से मेरा
वैसे ही धोखे आ रही है साइड में छूट रहे हैं इतना ना खींचो और ये टोटली ड्राई हो जाएगा एज इट इज रह जाएगा वॉशेबल भी है व्हेन द बेबी यू वांट टू वॉश आल्सो यू कैन वॉश ऑन द शीट ये लैरियोस्कोप है सर दिस इज अ लैरियोस्कोप
कल का जो सेशन है वो हमारे उन्होंने बताया कि बच्चों को फेलियर हो जाता है तो
Number 2 is in-person patient acute for transplant. So number 1 is biliary atresia, number 2 is acute liver failure. I have the list, I'll show it next time.
बच्चों की खासतौर से नवजात शिशुओं की बड़े बड़े बच्चों की और 18 साल तक बच्चों की स्वास्थ्य की बेहतर देखभाल कैसे की जाए, उनको बीमारियों से कैसे बचाव किया जाए और उन्हें राष्ट्रीय स्तर और अंतर्राष्ट्रीय स्तर का इलाज किस प्रकार से उपलब्ध कराया जाए ताकि वे बेहतर नागरिक बन सकें और उनके रोगों का सही प्रकार से इलाज किया जा सके। इस कॉन्फ्रेंस के अंदर हमने जो मुख्य समस्याओं को जिनको हम डिस्कस कर रहे हैं वे हैं बच्चे को गंभीर बीमारी की अवस्था में तुरंत कैसे बचाना जाए।
किसी का दर्द हो सके तो ले उठा, किसी के दिल में हो तो प्यार, जीना इसी का नाम है। लेट अस क्लैप फॉर द
I bring compliments from Concerned Health Secretary. Last 3 years of my tenure, in the 3rd year, I have met more than 500 members across country. We had a last year mission to show that we have sensitized India about the adolescent health care, leading to the self-motivation to pediatricians to come to AHA, which is the future of pediatrician in coming era. It is a social pediatrics, no investigation. You will have to investigate your mindset, how to deal with adolescent, the difficult problems, but we are not dealing with it. We are running away from the problems. I am thankful to Rajasthan IME for Rajpedicon organizers for inviting me in front of this august meeting. When you woke up in the morning, there are two news for the parents, for which they are afraid, they are fearful, they are concerned how to deal.
Okay. Sir, Bhupal. Okay.
I request Dr. Dipender Talishra is requested to hand over. We move.
Which was all about art of living, and now I am going to talk about art of protecting lives, that is in ICU. So of course I see a lot of young people over here, of course me too, who is taking more and more interest into intensive care practices with the blessings of madams. Both are sitting over here, and there would be motivation to all of us, where we will be seeing and reviewing our armaments. Like we have not many anatropes, dopamine, dopamine, adrenaline, renin, nitric oxide, cinnamon, blah blah.
Highly effective, can be given IV, good rates as an adjunctive drug in aborting status epilepticus. No serious side effects, can be given at 30 to 35 milligrams per kilogram as a bolus. Excellent safety profile, and no hypertension. Avoids the hypersensitivity of phenytoin, avoids the use of
something very significant, and I similarly, status epilepticus is a very important subject, and you know that status epilepticus, what is known otherwise, is not only the simple epilepsy which has gone for more than 30 minutes, but even if the febrile status is there, that is also very important. And a patient who is having convulsions with fever for more than 5-10 minutes, we should be very careful, and we should try to stop it, as Dr. Rani has rightly said, that if the control of convulsions is not there, then it will cause more of morbidity and mortality. So I again congratulate Dr. Rani for her excellent talk on the status epilepticus. Thank you very much.
जहाँ 40 to 60 milligram per kilogram per day. Patient presents casualty with status epilepticus, and sometimes patients since patient is already taking valproic again only with valproic acid. Or we should load phenytoin, since phenytoin is very important for acute seizures, and we should load this patient on valproic acid since patient is taking already valproic acid.
best to load again with valproic acid. Doesn't respond, don't give again, because usually you will find that people who are taking a drug at home, the levels will always be a little on the low side. So load with valproic acid again, you will top up the level. It may stop. If it doesn't stop, then go to phenytoin.
Yeah. And if suppose patient is already taking a maintenance dose of phenytoin,
give phenytoin. Give full dose of phenytoin.
And should we keep this patient on continuous maintenance dose of phenytoin?
Also,
And I request Dr.
thank you.
And I request our department who was afflicted in their presence at Jodhpur. We will be proud of him.
आपका ऑर्डर नहीं है क्या कोई? क्या टॉपिक बेटा? आपका आरडी। शुभम सर जी।
Dr. Manoj.
So would VBG be helpful in these situations? Like how do you interpret those things?
See, if you're looking at an, say, OPD practice, we are doing it for diagnosing renal tubular acidosis or a Bartter syndrome. It's not an ICU child. Then a venous blood gases is quite okay, provided you're not holding the hand too tight and the hand is not cold. If it's a kind of a warm hand and you're not tying a very tight to make it, those Vita, you can't use the venous blood
Diabetic ketoacidosis we can do.
We can do venous for diabetic ketoacidosis. All metabolic you can do.
Vomiting also we can do. Vomiting also we can do.
Yes. When you're not looking at the respiratory component, you're not very strictly. A venous blood gas for a pure metabolic analysis can be used. There's some small differences, but doesn't change your diagnosis.
pH by basic से same with light and PVC. How about O2 and CO2 are not
O2, CO2, even CO2 as a respiratory, it's a little difficult to rely on because it's, returning from tissues which have used the CO2 and it's coming back to the heart and the lungs. So the CO2 is likely to be higher. So if it's not a very sick child and you're doing it for a metabolic evaluation, it's acceptable. If it's a sick child,
So as scheduled.
Data showed that at least 2 children are diagnosed with a liver disease every day in United Kingdom. In terms of population, almost same in United Kingdom and Rajasthan. There are 100 different etiologies of liver diseases in children which are different from adults. There is paucity of data on chronic liver disease in children in India. We retrospectively analyzed children more than 18 years of age admitted with chronic liver disease from March 2008 to Feb 2014. Chronic liver disease includes infant with cholestasis, children more than 1 year with clinical and biochemical abnormalities in liver function for more than 6 months. We divided our cases in 2 groups. Group 1 include less than 12 months and in Group B for more than 12 months. Complete breakdown, liver function, gamma-glutamine transferase, prothrombin and ultrasonography abnormal burden in almost all cases. Upper layer of endoscopy and liver biopsy burden in most. Further workup was individualized as per age and clinical picture. So out of total 450 admissions, 99 patients have chronic liver disease, out of which 33 have infantile cholestasis and 66 non-metabolic causes. Out of 33 infants with cholestasis, 37 have biliary alcoholic fatty liver disease. So we concluded that cholestatic disease of infancy comprised almost 40.
age, weight and health. Total weight diabetes. So if from Vadodara means Gujarat.
I am sure the family will help you as to how you can deal with patient at your level. So, this is the case. Initially, we had thought of having 2 cases, and we were given 50 minutes. But with shortage of time, I think with due permission of all the panelists, we will reduce it to 1 case, so that we will be able to finish it within 25 minutes. So here goes. This is the chronic GI disorder. We will not have anything on hepatology, only on the liverology. The first case is of 18-month-old with complaints of on and off diarrhea since past 6 months. So this is the clear-cut case of chronic diarrhea. So if I have to ask question, maybe Dr. Alok. Absolutely. I think whenever you have chronic diarrhea, first thing is we have to identify the pathology. Before we go for the etiology, look at pathology, where is the likely lesion. So as rightly said, whether it is a small bowel or large bowel, maybe Dr. Ashish Gupta can throw light on as to what in history will tell us whether it is a small bowel diarrhea or a large bowel.
In the case of chronic diarrhea, it is very important to find out whether it is a small bowel diarrhea or it's a large bowel diarrhea. So whenever is suspect large bowel diarrhea, if there is history of small stools, frequent motions with the pain or with the mucus in the stools, and the pain is usually not periumbilical, it is other ways of the abdomen, and
क्या डिग्री है यार मतलब
MD पीडियाट्रिक्स
नहीं एंड सेक्रेटरी ऑफ NNF राजस्थान से
ये तो फैकल्टी है महात्मा गांधी के निम्स में तेरा नाम तो
Well friends, we talk about the rest such I'm working till now, and friends, as we all know, first like every time.
अच्छा प्रेजेंटेशन को
Breast milk, we all know the best. The breast milk is the best nutrition for the newborn and the young infant. At the same time, we all know that it is useless if he or she is infant. How is an infant protected against infection? General and mechanical factors, immune protection from the mother before the birth, bacterial colonization from mother at birth, infant's own immune function, and the protective factors in the breast milk. We are focusing here mainly on the protective factors in breast milk. And immune system has many components. One of them is cells, neutrophils, differently lymphocytes T or B, immunoglobulins IgA, IgG, non-specific factors.
Replicated cannot be produced in any of the laboratories, and now we have gone to that stage that extra milk can be stored and human milk banks are being established. In Udaipur we have established 2 years back. All over nation in last 2 years 10 banks have come, and just by giving human milk in NICU and PICU, the recovery rate is 30% earlier, saving that much of economy also. And it can be preserved for 4 months, and loss of all live materials, macrophages, etc. is just 1%.
And I request Dr. S.K. Taksar to give moment to Dr. Paliwal sir. Please Sanjay. And I request Dr. Asif to give moment to Dr. Sanjay, the chairperson. Now for the on how to set up an NICU, and this is a topic of national priority because government is setting up NICUs at different levels, SCNUs at medical college levels. And to talk upon this topic, I am inviting a very young, dynamic, dedicated and very social pediatrician from Jaipur, Dr. Dhananjay Mangal. He is having
I'm feeling pride and privilege to be here in my own institute where I learned ABC of medicine. So from this hour we have started our life, medical life. I am thankful to our team, especially Dr. Suresh Goyal sir, Dr. Lakshmi Poswal, those who have invited me to for this talk. Newcomers, new young pediatrician to set up some sort of NICU at different levels from the periphery to our medical college. So we have to know something about what is the aim of the NICU setup.
And I invite Dr. Devendra Sanisha to give moment to our chairperson, Dr. A.P. Gupta sir.
Thank you.
So before I invite our national hero, Dr. Abhishek Bansal for his next talk, that is an important oration on Dr. Puneet Sharma Memorial Trust.
It's a privilege for me to share this session have been the student of this medical college. I passed my MBBS in 1984. Regarding Dr. Samir Gupta, most of our eminent persons know, but it's my duty to introduce him. Dr. Samir Gupta is the alumni of the RAJ Medical College. He passed his MD from this medical college, and presently he is the Professor of Neonatology.
Delegates and my dear friends, indeed it's my privilege to be home and enjoy the feast of academic pediatrics and neonatology the last 3 days. My sincere thanks to Professor Goyal, Dr.
Most of our level 2 and level 1 unit do not have the facility of echo. Is there any place for additional hemodynamic assessment like BP? Since early EG, we are learning that blood pressure is an effect of cardiac output and resistance. You know there is no correlation of cardiac output and BP.
So that he is already covered very nicely.
Is there any place for the
We have a limitation of time. This year already covered very nicely the limitations and advantages of BP.
So is there any place for the cat's eye or rather than Einstein's brain?
See, I would not want you to change your practice right away. The practice that you have learned clinically, it is not a substitute for a clinical medicine. It is an additional tool with the clinical medicine. So we can't give that away. What we need to be cautious is just depending on the clinical science is not enough. And where you are worried that this child is not good or not performing well, please look for other methods.
The organizing secretary of Pedicon 2011.
Is in the memory of Dr. Punishan, who was working as assistant professor in pediatrics at Jaipur from April 2005 till February 2008. And he was the son of
Good morning, Professor Suresh Goyal, my teachers, colleagues and friends. Well, I cannot express in words how I feel today when I stand in front of you all. By considering my name and giving this opportunity to speak on this prestigious Dr. Punishan oration is a great honor to me, and maybe I do not deserve this. But Professor Goyal, Lakhan Goswal insisted that you should do this job. I'll try to do as much as just possible with this oration. Well, what makes me more nervous is the presence of Dr. Lucky Jain and Dr. Samir Gupta. They both are here and I'm speaking in front of them. Last year Dr. Lucky Jain spoke on this oration and I was present there at Bhupal.
जो प्रोटोकॉल है आपने बिल्कुल समराइज प्रोटोकॉल दिया उसके लिए आपको बहुत बहुत धन्यवाद देना चाहिए और सच टाइप ऑफ लेवल 3 प्रैक्टिशनर को ऑलरेडी स्कॉलर है और आगे भी मैं चाहूंगा सुरेश को इससे रिक्वेस्ट करेंगे कि यहां पे और भी जितने लेवल 2 प्रैक्टिस के लेक्चर हैं उनको टाइप जल्दी दें थैंक यू वेरी मच सर जो बोर्ड अराउंडिंग है कि हमें अर्ली सेट करना पड़ता है कुछ ईयर से बेबी आउट होने से पहले उसके लिए कोई आपका कमेंट बोर्ड अराउंड नेक
Normally in maternal religion, see, when the baby comes out, what new NRP says, new resuscitation, neonatal resuscitation, you have to ask 3 questions to yourself. Is the baby dumb? Is the baby vigorous? Is there good tone? There is no question of having color or cord round neck or anything. If the baby is vigorous and good tone, then let it be.
Yeah.
So the controversy regarding taxa.
आप दे
आप ही
This is for your convention.
I have to say that there are sad moments in life
but the joy of having so many friends and well-wishers around us is the biggest comfort we can get and contribute to each other. And I think that we have to get all the best. So my thanks as well to all of you, to Dr. Koswal, Dr. Suresh Goyal, Abhishek. Where are you, Abhishek? I'm here. Okay, I think I remember to put your eyes all over the world. If you go ask people why they don't carry prostaglandins, why they don't, I don't know, Samir, what you all do in England, but in the US, every level care center now carries prostaglandins. And our transport team carries prostaglandins. Our instructions to the transport team is that if you suspect congenital heart, start prostaglandins. There are some situations where you could have temporary deterioration. Some babies respond with apnea to prostaglandin therapy, but in general, you could actually save a life by instituting quick therapy. So, these are the common lesions that you deal with, be cyanotic or cyanotic, and you'll see that, of course, cyanotic lesions are many, mostly of the right side of the heart, tetralogy, of course, mixing lesions like transposition, tricuspid atresia, and truncus arteriosus, and of course, the acyanotic ones, largely the shunt lesions. But this is, the more important thing is understanding the fact that the heart, fetal heart, is moving in a very, very coordinated fashion. And after birth of the child, many of those issues will continue in the same manner. Our role is to make sure that the fetal physiology is not what has taken over, at whether it's 5 days or 7 days after life. And one of those conditions that you worry about is pulmonary hypertension. So we mentioned a little bit about, this is a study that showed in pediatrics published from Wayne State, which showed that in mothers who did not report any use of non-steroidal anti-inflammatory agents like ibuprofen or aspirin, when babies who had pulmonary hypertension, they looked at traces of these agents in the meconium of the baby. They found in 44% aspirin, 23% ibuprofen, 19% naproxen, and 8% indomethacin. So what's happening is that many of these mothers are taking cold medications, or the knee is hurting. The mother-in-law says that here is a pill, you're only 3 weeks away from delivery. It shouldn't matter anymore whether or not you take this medication. The ductus closes. So in my lab, if we close the ductus artificially and put the fetus important, the ductus generally joins over here. Some of the blood vessels have taken off, and of course, if the ductus is closed, then how will you have cyanosis in pulmonary hypertension? Yes, absolutely. What did you say? Yeah. So you'll have atrial level shunting through the patent foramen natale. Of course, the atrial level shunting will not give you a difference. It has already occurred within the heart. And of course, one needs to just remember that when you think about fetal circulation, there is the ductus venosus as well, and the placenta forms a part of a very large, low resistance circuit. And so if the heart is weak and cardiomyopathy, it will manifest fairly early within the neonatal period after the cord is cut. The timing of clinical problems in these babies is, of course, in the first 1 to 2 weeks.
Went down to Sri Lanka a couple of years ago, and they have really made huge strides in their neonatal mortality, and it's an envy for South Asia to have neonatal mortality nearly single digits. And I think there is, when I went to Sri Lanka, I found that there was a lot of coordination, a lot of discussion amongst various colleagues in pediatrics, and they have had a concerted effort to bring their neonatal mortality down. So I've just shown that figure to compare it with.
Sir, you want to say something? Now, I request another chairperson. Now, the atmosphere is an assistant professor, Department of Pediatrics, Division of Gastroenterology, Hepatology. So, he did his graduation, basic science graduation from Stanford University, California. He did his MD and PhD from Harvard Medical School, Boston, Massachusetts, and he did his residency and fellowship, and now he's working in Texas Children's Hospital, Houston, Texas. Yesterday he really mesmerized by his talk on hepatic encephalopathy and liver transplantation, and now he will speak on.
So for the indication of vaccination, please refer to the vaccination guidelines of Indian Academy of Pediatrics.
Because when patients comes to us, they are chronic respiratory disease, need pneumococcal vaccine. So whether it is we can recommend pneumococcal only for case clinic condition or any VSP or increased flow situation, they ask from your
Presently, the vaccination guidelines for Indian Academy of Pediatrics says pneumococcal vaccine should be given to high-risk patients after discussion, after one-to-one discussion with the parents. That
2014 has been a defining day in the history of healthcare in India, when we launched Indian Newborn Action Plan. And I'm sure many of you must have read about it. And I suggest my postgraduates to be ready with this. Maybe an exam should be a short note on INFE, because this is such an ambitious.
So how do we assess the severity? Because there are various scoring systems for predicting the mortality of the well-developed babies, but most of the scoring systems are either developed in the United States or in European countries. The scoring system that we use in our study is the CRIB score. It includes 6 parameters, that is the birth weight, the gestational age, the congenital malformation, and 3 more, that is base deficit, minimum effect required, and the maximum effect required. But the 3 of the 6 parameters, that is the base deficit, minimum effect required, and the maximum effect required, they cannot be derived at all places in our country. So what is the relevance of this score for us? Can this score be derived at all places? A medical officer at MPS Telecom, can it have this score? Probably not. It is questionable at district hospital also. And at a medical college, yes, we can have the score surely. But will the mortality remain same, even if the score is same for all the babies and all the 3 places? Because of the different resources, the mortality will not be same. So, with this aims and objective, we conducted a study to find out the mortality of very low-mortality babies admitted in our NSU, and to develop and validate a modified score for neonatal mortality prediction that is applicable at all levels, that is primary, secondary.
I request Dr. Mandora sir, my teacher, to present a memento. Thank you, sir. And now
can you get the next one? Okay. So this one, I'll touch up few examples. Probably that would be the model of survey. Preterm 36 week NICU days. Okay. Preterm sent home after NICU days, 15 days stay. 2 months he comes to you, from a regular follow-up, comes with the indicated head circumference. Okay, CT scan shows hydrocephalus.
I'm sure the answer should be yes. From grandfather to grandson, like the color of the eye. The lifestyle is between the sisters, between the brother and sister and cousins. You see a basic similarity between all of them. So why is there, if the answer is yes, so why is there a similarity? The similarity is because of the 3-letter which is known as DNA, which we all of us have. And this is passed from one generation to next. And this is what is genetics. So coming to the technology, in a new...
Also requires big applause because he has very successfully, without any hassle, managed the registration part, especially for the residents. And the residents have worked hard. They prepared different chapters, and this book is really a good milestone on this occasion, on the occasion of this conference. And Dr. Bhupal also deserves special applause because under his leadership, he really did very hard for publication of this book. And practically everybody in the department has really worked hard. Dr. Malik, he took care of the reception. Everybody, I am really thankful to the teamwork, and I am thankful to Dr. Goyal for giving me this opportunity. Now I request, because the residents are very nervous. They were aggressive yesterday also. I think they enjoyed the banquet yesterday. So Dr. Suman is here for announcing the prizes of post and paper presentation.
Just a minute. First of all, our chairperson, Dr. Suresh Goyal sir, who led us the path of how to make this foundation successful. Dr. Suman sir, he is office hours from morning at 8 to 9 in 2 a.m. And again in 2 a.m. today he was ready here with same energy level. And Dr. Suresh Goyal sir, the way he has directed us, the way he has guided us to do the things, it was dynamic. And we expect that in future also we organize National Pedicon 2017. We'll be having a bit under guidance of these 2 leaders.
All the homework, the backstage and preparations are done by Asif. He's so meticulous. He's really kept account of everything.
आओ कम खा जाओ आओ इधर आओ जैसे कि आओ
Thank you so much. Dr. Suman. Our clerical staff, the department, and especially Prem also worked very hard. I request both sir to give the memorandum to Prem also, and a shawl also. Ashok ji, the audiovisual arrangements were done by Ashok Singh ji very well. So I request both sir to give the memorandum to Ashok Singh ji also.
इन्होंने बहुत फोटो खींची अभी इधर आओ
Shri.
He projected his study very nicely and he defended his study very nicely.
Akash is not here.
You can click on his name. The poster competition in pediatrics which was held yesterday. The second, Dr. Mamta Bajar. The pediatric. Position, there are again two candidates. Dr. Singh, she is from Jodhpur. Singh Agarwal.
good day.
And on third position, again from Jaipur, Mahatma Gandhi Medical College, Dr. Divya Bohra.
Very good.
In post competition in neonatology, Dr. Kuldeep. Dr. Kuldeep. He is from Udaipur. On second position, Dr. Pinky Gupta. Pinky Gupta from Fortis Jaipur. She has left. Come. And on third position, Dr. Sameer Jagarwal from Bikaner. Dr. Sameer Jagarwal. No? Anybody from Bikaner?
Anybody from that place? Bikaner ko na?
I think this was the most fair decision in paper competition. We have not done anything whatever the judges have decided to get in this paper.
We have two sections. Those who are not leaving the town today, they can collect for benches at Hotel Paras Mahal after half an hour. After 1 hour, 8 p.m. You will enjoy there. Okay? Thank you.
Till last, thanks to all of